Leigh, are you okay if we get started? We'll probably have a few more filter in soon, but
Sounds good. Let's do it.
Great. So let me start with this very important disclaimer, which is that our speakers have been invited to share their personal perspectives, but they do not speak for Harvard. And with that, let me introduce our esteemed guest and alumni, Leigh Senderowicz. She is let me pull up your title. Sorry, I just closed it in order to find my disclaimer. She's an assistant professor of gender and women's studies and of obstetrics and gynecology at the University of Wisconsin-Madison. Leigh earned her master's of public health from Johns Hopkins, her doctorate in global health and population from right here at the Harvard Chan School. And her research explores global reproductive health with a focus on rights-based and person-centered measurement. And I am really excited to have her here. I jumped at the opportunity to invite her. I teach her work on contraceptive autonomy in my undergraduate class on maternal and reproductive health, and she's really leading voice in the work of coercion and choice in reproductive health. So we're super lucky to have her here. So Leigh, please take it away. Welcome back to GHP.
Thank you so much for that, Jessica. It means a lot. I don't normally
You're
get
muted.
nervous.
We're missing your.
I'm muted?
I can hear you.
You can hear me? Okay.
Oh, good. Now I can. Hello?
I hear you too.
There we go.
Yeah.
Okay. I don't normally get nervous before talks anymore, but I actually felt a little bit nervous before this talk. Because this is the community that trained me and nurtured me. And so it's really just like a privilege and an absolute honor to be back here with you. So Jessica, thank you so much for the invitation. Let me share my screen here, and can I just get like a thumbs up? You can see my slides. Okay, great. For those of you who don't know me, I came out of GHP, and I consider myself an interdisciplinary mixed methods researcher, trying to merge the worlds of global health, social demography, and gender studies. And I spend a lot of time thinking about reproductive health and autonomy, with a particular focus on this feedback loop between how we measure things and what programs do, and then how we measure those programs and then what they do. And with the understanding that what we measure impacts how we understand the world around us, I look at reproductive health indicators as a gendered and racialized form of knowledge production, and then I try to think about how we can sort of better design those metrics to advance reproductive justice in global health. And so today I'm going to be talking to you about that in relation to coercion and autonomy in family planning programs, now 30 years after Cairo. So just very briefly, I'm going to start with some background on coercion and autonomy in family planning and the rationale for why I started this project. I'll spend a moment on what I like to call the tacit ideology of measurement before moving on to the contraceptive autonomy study, which is sort of the centerpiece of my research agenda. And I'll share some of the findings from that study. And then I'll finish with just a few words on what I hope we can all take away from this. So let's just get started quickly with some context. And I like to ask the question, like, why should we care about family planning? Why do people come to family planning? And the answer to that is really different, depending on who you are. So different people come to family planning for a lot of different reasons. There's a ton of diversity in who's in the family planning movement. So we have a feminist rationale for family planning to promote contraception as a matter of bodily autonomy, an environmental rationale to protect biodiversity and alleviate climate change. There's an economic rationale to increase economic growth, pursue a demographic dividend, reduce poverty, and a public health rationale to promote maternal and child health. And this is a screenshot from a family planning advocacy website that shows how all of these arguments are sort of deployed at once and mixed together. So this website frames family planning as, quote unquote, the smartest investment that we can make, capable of improving outcomes in everything from HIV/AIDS to education, to sanitation, to malaria, as well as bringing significant savings across sectors, right? So in this way, we can see how family planning is really portrayed as almost like a silver bullet for the multidimensional challenges of global poverty, unsafe living conditions, and ill health. And with so much upside and almost no stated downside, the challenge for family planning practitioners has been framed as how can we maximize uptake to its highest levels possible? But of course, we need to remember that despite all of these purported benefits, family planning has not always been an emancipatory project for all people, right? So family planning has been tied in with a range of efforts to control not only fertility overall, but also to decide whose bodies are targeted for fertility reduction. In the US, the eugenics movement targeted the bodies of marginalized racial and ethnic groups, disabled people, people living in poverty, among others, for compulsory sterilization. This is a photo of civil rights activist Fannie Lou Hamer, who you might know from her voting rights work, but she also helped us understand the term Mississippi appendectomy, which is a slang term from the US South to describe the involuntary sterilization of Black women that was taking place. And this actually happened to Ms. Hamer herself when she was given a non-consented radical hysterectomy by a white doctor in 1961 when she was undergoing surgery for a small tumor. In the global South, neo-Malthusian concerns about global overpopulation were really central to the birth of the development sector after the Second World War. So USAID was founded in 1961, and in that first year of its existence, it began funding family planning research as one of its very first activities. This is a screenshot from the USAID family planning website. And you can see how Presidents Kennedy, Johnson, and Nixon, so Republicans, Democrats, everybody, were all motivating US development assistance for family planning as a way to control overpopulation in poor countries. President Johnson said that he would seek new ways to use our knowledge to help deal with the explosion in world population and the growing scarcity of world resources, while President Nixon called population growth one of the most serious challenges to human destiny. One of the most serious challenges to human destiny. So given these supposedly stark and even apocalyptic stakes, the legitimacy of coercion in the pursuit of fertility decline was frequently affirmed throughout this era. The president of the Population Council in 1979 was a man named Bernard Berelson, and he wrote this paper in PDR advocating for what he called a stepladder approach to the population problem. So he wrote that there are undoubtedly cases of justified coercion, but he argued that overt violence or other potentially injurious coercion is not to be used before non-injurious coercion has been exhausted. So like the stepladder approach is like only escalate to more violent coercion if it's absolutely necessary to get people to have fewer children. And many countries in the global South adopted population policies that included penalties for high fertility, quotas for providers, and compulsory sterilization for women. So for example, in Singapore, whose family planning messaging you can see there on the right, actually no, on the left, where there were financial penalty levels, financial penalties were levied among families who had more than 2 children. And in India, even to this day, there are still financial payments and other incentives for women who get sterilized that the amount of the incentive is based on how many children they already have when they agree to get sterilized, with lower payments for people who already have too many kids. So feminist scholars have been really active in describing the ways that scientific racism, medical misogyny, and Western hegemony have been sort of suffusing this development project from the start, and in particular, the ways that the gendered and the racialized logics of global family planning have targeted poor women of color living in poor countries for fertility reduction. And importantly, feminists from around the world have organized to contest the types of reproductive violence that have been perpetrated in the name of population control. So here you have a poster from a San Francisco-based artist named Rachel Romero. She created this image in 1977 to contest the forced sterilizations that were going on in California at the time. And all of this really came to a head, I think, as many of you already know, in 1994, which was the year that the UN organized the International Conference on Population and Development in Cairo. And this became the really sort of like well-known reckoning, right? Where a substantial and really well-organized feminist opposition confronted the population control movement and demanded an end to coercive family planning And so to quote this article in The Lancet from my own advisor, Anna Langer, she wrote that the Cairo conference put the ideas of comprehensive sexual and reproductive health and rights, choice, women's empowerment, a life cycle approach, and gender equity at the center of the international agenda and signaled the end of the so-called population era. And so the conventional wisdom is this claim that the Cairo conference really changed everything. It was this watershed moment that created the post-Cairo shift, in which the pre-Cairo focus on population control and fertility reduction was replaced by a much more holistic focus on reproductive health and rights and gender equity and quality of care. But sort of the central argument of my talk today and of my work more generally is that this post-Cairo shift has been much more successful as a rhetorical move in terms of changing what we talk about than it has been as a substantive move in terms of changing the orientation of family planning programs away from fertility reduction. And I'll show just a few examples of how that orientation towards population control and fertility reduction remains very much intact in state-sanctioned programs, even in the years since Cairo. So there have been efforts to control fertility overall, like the one-child policy in China, that I'm sure you're all familiar with, that was in effect until 2016. Efforts to keep promoting non-consented sterilization, like these sterilization camps from India, which also operated through 2016. There have been efforts focusing on ethnic minorities, like in Peru, where indigenous women were targeted under the Fujimori government until the year 2000. There have been efforts targeting people with disabilities or living with chronic diseases. This is a case from Namibia in which women living with HIV were targeted in 2012. Certainly many examples where people of color or people of African descent are being targeted, like this case from Israel from 2013. People who are trans, gender expansive, or non-binary have been targeted, like this example from France from 2017. People who are poor living in poverty are often targeted, like this example from Australia from 2014. People living with intellectual disabilities are targeted, like this case from the UK from what year is this, 2015. And in the US, I really had sort of my pick of examples, but I went with this one where we were targeting people who were incarcerated. This is an example from 2017. And so here you have examples of contemporary contraceptive coercion from every inhabited continent in the world, targeting just about every kind of marginalized group you can think of across axes of race, ethnicity, gender, disability, class, geography, coloniality, and more. But I want to be really fair here, because these headline-making cases of rights abuses are a really far cry from how most mainstream global family planning programs operate day to day. And I really want to give credit where credit is due. Virtually all mainstream family planning programs have denounced these types of overtly coercive practices, and they're taking a lot of care to affirm the importance of voluntarism in their programs. So we talk a lot now, not about family planning, but about voluntary family planning. And so I think it would be really easy to dismiss these types of cases as outliers, maybe the result of a few rogue programs, a few rogue providers, some out-of-touch bureaucrats who don't really get it, but not really representing the core of mainstream family planning. But what I want to argue is that the reality of stratified reproduction and this ideological focus on keeping certain kinds of people in certain places from having too many babies remains really woven through the heart of the contemporary family planning movement. And you can see that, I think, if you look at our research agenda in the global family planning field. So I'm going to spend a moment here on what I call the tacit ideology of measurement. And I know I don't need to convince this particular audience, we probably know better than anyone in the world, that measurement really matters in all kinds of important ways. But I really love the perspective from this quote from an anthropologist called Sally Engel Mary. She has a book called The Seductions of Quantification. And Mary writes that statistical knowledge is often viewed as non-political by its creators and users. It flies under the radar of social and political analysis as a form of power. Yet how such numerical assessments are created, produced, cast into the world, and used has significant implications for the way the world is understood and governed. So although our indicators might seem like objective counts of a given phenomenon, what we choose to measure and how we choose to count that thing are actually just political decisions, right? That are reflecting the the political worldviews of the people who are making those decisions. And so I spend a lot of my time thinking through the tacit ideology of our family planning measurements, what types of power these measurements are wielding, whose worldview our indicators help us see, and in turn, whose worldview, whose perspectives do these indicators obscure. And so here's a list from USAID and Data for Impact of some of what they call the core indicators for family planning. And if we look closely at what's being measured by these indicators, you can see measures of contraceptive use, modern method use. We can see fertility desires, age-specific fertility outcomes, measures of method mix, and measures of contraceptive knowledge. But it can be kind of shocking if you step back and you realize that actually none of these, not a single one of these measures is a health outcome. None of them measures rights in any way. We could maybe have a conversation about access, maybe. I would argue that access isn't really represented here. And equity for sure is also not represented here at all. So if what we care about in this post-Cairo agenda is health, rights, access, and equity, shouldn't we be measuring those things, right? Shouldn't that be at the top of our measurement agenda? I love this example from the bulletin of the WHO. This is a sort of a report out of a meeting that the WHO convened to conduct a priority setting exercise for family planning research. And so they arrived at this long list of 15 highest research priorities. And let me zoom in so you can see at the top few measures. And so they decided that the number one area of interest was to identify barriers to uptake. The number two area of interest was to figure out how to improve uptake. The number three area of interest was how to increase uptake. And the number four area of interest was how to overcome barriers to uptake. Now, I'm being maybe a little bit unfair here. We can see that sort of what type of uptake or which population's uptake varies by indicator. But we really can see that while our overwhelming sort of focus, our rhetoric has been transformed in the years since Cairo, our measurements really haven't followed suit, resulting in this sort of fundamental misalignment, right, between our stated goals on the one hand and our current measures on the other hand. And mainstream global family planning measurement is still really based in this idea that we need to get everyone in the world, every woman in the world using a method, and uptake is our goal. And it's not just an academic question, right? I know I don't need to convince this population in particular that what we measure really has these tremendous implications for how programs get funded, designed, implemented, evaluated, and then back again. And that's been actually particularly true in global family planning in the past decade or so, the past 12 years or so. Many of you may already be familiar with this initiative called FP 2020, now called FP 2030. It began in 2012, and it was led in large part by the Bill and Melinda Gates Foundation with an objective to add 120 million additional users of modern contraceptive methods by 2020 in the world's poorest countries. And in the words of the program's architects, the success of FP 2020 will first be evaluated on the basis of quantitative verification to determine that the 120 by 20 goal was reached. That overarching sort of global FP 2020 goal in turn spawned a set of regional and national commitments that were pursued and measured in much the same way. So one really well-known example is the Ouagadougou Partnership, which was a regional initiative of 9 Francophone West African countries that together pledged to add 2.2 million new users of family planning by 2020 across those 9 countries. Here's an excerpt from Ghana's commitment to the FP 2020 program. This included both an aim to increase modern contraceptive prevalence from 22% to nearly 30% among married women, and from 32% to 40% among unmarried women. And they also pulled from their population policy to affirm a goal of reducing TFR. So not just seeking to increase contraceptive uptake, but to reduce fertility from 5.5 children to 3 children per woman. And then some governments set even more specific goals than that. This is a screenshot from the Burkina Faso National Plan to Accelerate Family Planning that they developed under the auspices of FP 2020. And let me translate it into English for you if your French is a little bit rusty. So the government set not only an overall target of getting contraceptive prevalence up to 32% by 2020, but they also set method-specific targets to guide how they wanted to reach that uptake target. And so this plan for increasing contraceptive use focuses specifically on promoting the use of long and medium-acting methods, focusing specifically on IUDs, implants, and injectables. And so it was this global context that led to the sort of overarching research questions that keep me up at night. The first is, what happens to people's experiences if or when fertility goals are what drive family planning programs? And the second is, given the importance of quantitative measures, how can we design population-based family planning indicators that really do promote that post-Cairo agenda of reproductive health and autonomy, as opposed to that pre-Cairo agenda of population control? So that's where the contraceptive autonomy study comes in. This study began as my doctoral dissertation in GHP and has now gone on to be really the centerpiece of my research agenda. And the goals of this study are to better understand how contraceptive coercion manifests and to build a fundamentally new approach to family planning measurement that promotes reproductive freedom. So this was an exploratory sequential mixed method study that I designed using a formative qualitative research phase to inform the development of a novel large-scale quantitative survey. I'm going to anonymize the country setting today for purposes that some of you already understand. I'll be happy to talk about during the Q&A, but this is a country in sub-Saharan Africa that has won international acclaim for its family planning program, with the idea that if coercion is found in this highly visible and award-winning program, it might be reasonable to hypothesize that coercion is a problem through similarly conceived family planning programs around the world. So I'm not going to spend too long here on methods, but our qualitative phase consisted of in-depth interviews and focus group discussions with women of reproductive age, as well as some key informant interviews with health administrators. This helped us understand what kind of experiences people were having, what types of language, what words they use to describe those experiences. And that in turn helped us develop new survey questions that we thought would make sense given the experiences that they described. And so we conducted that survey with over 3,900 women of reproductive age. And I'm going to give just a brief taste of our qualitative findings and then spend the rest of our time today on how we're developing this new measure. So the main thing to come out of the qualitative phase that I want to highlight for you is what I call this sort of comprehensive theory of coercion. And this theory has three parts. The first part is that coercion sits on a spectrum. It's not a binary outcome. The second is that coercion is structural in addition to interpersonal. And the third is that coercion is bidirectional. And I'll just spend a second on what I mean by each of these. So the finding that coercion sits on a spectrum, I think, is one of the most important outcomes of this work. I'm arguing here that it's actually much more helpful to conceptualize coercion as an increasingly injurious array of practices that limit contraceptive decision making, ranging from the subtle to the overt. So this is sort of a callback to Bernard Berelson's stepladder approach to coercion. Things like biased counseling, limited method mix, and the provision of false medical information are mapped on the spectrum as sort of subtle coercion, less injurious coercion. Threats to deny future care, scare tactics, and insisting are mapped as moderate coercion, and then inserting methods without consent or refusing to remove provider-dependent methods are mapped onto the more overt end. And so what this does is help us understand things like a limited method mix as a type of coercion in a way that it wasn't really conceptualized that way before, as a way that structural forces limit people's ability to exercise contraceptive autonomy. So here's a quick example of what we mean when we talk about subtle coercion. We asked Maria about her contraceptive counseling, and she tells us, well, the health workers normally counsel you that if you want to choose, you have to choose the 5 years, the implant. Now, if that method isn't suitable for you, you can take it out and get the 3 months injectables. But if you don't like that, you can't take it out. You have to wait for the 3 months to be over. Otherwise, you can't remove it. So it's the providers who told you. It's true there's counseling and they tell you to choose what you like, but what they think is best, it's only the 5 years, the implant. And so I've called this type of like clearly directive and biased counseling a form of subtle coercion. There's no use of like threats or violence, but it's clear that Maria is describing a situation in which decision-making autonomy is constrained by the provider's preferences. And then sort of mapped onto the other end of the spectrum, we have Jessica's story. Jessica says, when I got pregnant with my 10th child, the midwife told me that I have a lot of children and that I would have a difficult delivery. The health workers in a nearby town said that I needed to get the implant by force. I was obligated to accept, and they gave me the implant. The nurse told me that it would be 5 years. And even before the date of the 5th year, I started to feel illnesses due to the implant. I went to tell the hospital that I got headaches from the implant, and it's there that the health worker told me that the date to remove it hasn't yet arrived, so he can't remove it. He refused. He said that it hasn't yet been 5 years, and there are 2 months that still remain. So there's a lot going on here. I'm going to focus on just a few things. Jessica was forced to get an implant due to a provider's perception of high parity. It doesn't seem that she was given a choice either about whether to use a method at all, and then about what method she wanted to use. And then instead of viewing the 5-year duration of the implant as the maximum period of efficacy, many women told us stories of providers treating that 5-year period as the minimum duration of use, and sort of categorically refusing to take them out before that time had elapsed. Here's an example of what I'm calling structural coercion. We spoke to a health administrator who supervises family planning clinics, and he told us at the district level, we also give goals to each health center so they can attain the targets. Those that are concerned with all the methods mixed together, but above all, the long-acting methods that we're really emphasizing. And so I'd love to give you a lot more detail on this, but just to sum up, I feel like this quote helps us gain an understanding of contraceptive coercion as something that's not just interpersonal based on like a bad apple, but something that's stemming from policies and programs. In much of the thinking around coercion, we tend to focus on like intent to coerce or on individual providers. And I think this has really distracted us from looking at the root causes of coercion. And so instead of blaming providers, if we understand coercion as structural, this can help us reframe the situation and place the critique back onto donors and onto program designers in the global north, because the systems that are in place were designed, as we saw, with the express goal of achieving contraceptive uptake. And so why should we be surprised then when rights and autonomy are subordinated to those uptake goals? And then finally, I won't go into this one in more detail, but I wanted to mention what I mean when I talk about the bidirectionality of coercion. Coercion has been conceived of traditionally as when someone's forced to use a method that they don't want, like in the examples that I've just shown. And of course, this is a really important form of coercion that we need to pay attention to, but it's not the only form. So often people are deprived of a method that they do want. And so here I've called the inability to use a wanted method as a form of downward coercion. And I think that understanding these two phenomena as actually manifestations of the same types of reproductive control will be really important for us moving forward as we start to pivot from alarmism about high fertility now to alarmism about low fertility. And so then bringing these 3 ideas together, this theory sort of rests on the contention that all obstructions to contraceptive autonomy, upward and downward, structural and interpersonal, subtle and overt, should all be understood and analyzed as various iterations of the same process, which is coercion. And so that part was challenging in some ways, but it ended up in other ways being the easy part, because the hard part really was, now that we understood these things, this complexity, how do we design novel survey questions and a contraceptive autonomy indicator that would be able to capture some of this nuance. It's really hard. The bottom line is it's really hard. So here we go. How do we measure contraceptive autonomy? Well, we knew we had to do something pretty different from the status quo, because for most of recent history, the outcome of interest to the family planning community has been contraceptive use. And we've been measuring this in a super straightforward way and interpreting it as someone who's using a method, that's a good outcome, and someone who's not using a method is a bad outcome. And this simple dichotomous measure is at the core of just about every population-based family planning indicator we have, from contraceptive prevalence to unmet need. This is underlying everything. But if we add just one additional criterion to what we measure and also examine the extent to which a person wants a family planning method, we can begin to create a more person-centered understanding of family planning. So if we add this new criterion, can we say that this column to the right is still always good, and is the column to the left still always bad? I suggest a new definition of success for family planning that's not dependent on the person's status as either a user or non-user, but rather on concordance between what the person wants and what they have. And it's based on this concordance that we're trying to develop this autonomy indicator. But as I'm sure all of the behavioral economists are screaming in their heads, what does it mean to want family planning? And how can we create a measurement around this? Because we all know that a lot more goes into autonomous decision-making than just a person's feelings. So we decided to define contraceptive autonomy as the factors that are necessary for a person to decide for themselves what they want, and then to realize that decision. And then drawing on the work of Karen Newman and Charlotte Feldman-Jacobs, I identified 3 subdomains of contraceptive autonomy: informed choice, full choice, and free choice. Informed choice is when a person has sufficient unbiased information about a range of family planning options, including the benefits and the risks of both use and non-use. Full choice is when a person has a sufficiently wide range of methods from which to choose. And then free choice is a decision made about whether or not to use contraception and what method to use, made voluntarily without barriers or coercion. So I'm not going to get too in the weeds about how we're operationalizing this, but if we sort of bring this back to our contingency table, in box A, now we have people who made a free, full, and informed decision not to use contraception. In box B, we have people who are using a method but lacked informed, full, or free choice in their decision to use. Box C are people who are not using but lacked information, access, or freedom in the decision not to use. And then in box C, we have fully autonomous users. And then with that schematic all mapped out, we can start thinking through indicators. I'm thinking through changes to the unmet need indicator based on this. I'm thinking about an autonomy adjusted contraceptive prevalence. But sort of the core indicator is just the contraceptive autonomy score. And this would just be a simple proportion of autonomous users over the population as a whole. For those of you not from the family planning field, you might be looking at this and thinking like, big deal, like this does not seem revolutionary to me at all. But to my knowledge, this is the first and only population-based family planning indicator that acknowledges that autonomous non-use of contraception is actually a perfectly good outcome that we should give credit for. And so the thought is that if we could pursue contraceptive autonomy targets rather than contraceptive uptake targets, we would eliminate some of those structural incentives for coercion. And so we piloted this idea in Burkina Faso in 2018. This was the subject of my dissertation, as I mentioned. And I'm not going to do a deep dive into our quantitative findings, but they are published. So if anyone's really interested in what we found when we tried to pilot this, please go check out this paper. But I will say that our first attempt to measure this, I think, probably taught us more about what doesn't work than what does. And so I guess what I want to emphasize here is that we really still have quite a long way to go before we figure out a lot of these really sticky measurement challenges. I'll just highlight here, one of them is that measuring free choice ended up being like the hardest thing in the world. The qualitative data that I shared with you earlier, I think suggested quite strongly that there's a lot of pressure to use methods and provider reluctance to remove LARC in our sample. But when we asked questions about that in our quantitative survey, we saw that very few people answered yes to feelings of pressure or non-voluntarism. And of course, one perfectly reasonable explanation could be that our qualitative sample was not indicative of what's really going on, and that there are not many people experiencing non-voluntarism, and that our questions were sort of accurately estimating the true population levels of coercion. But I'm a little bit more inclined to believe that coercion is indeed an important factor in this population, but we just haven't found the right way to try to capture it yet through survey questions. So women might not want to admit to themselves that they were coerced, or they might not know that the providers were lying to them. There might be a lot of post hoc work to reconcile cognitive dissonance, or social desirability bias, not wanting to admit to an interviewer what was going on, or perhaps believing that the interviewer was connected in some way to the health system and being afraid of reprisal. So there's a lot going on there. And then, of course, we know from the field of disrespect and abuse in maternity care that there's also a lot of normalization of low quality of care and of abusive care that people might not be sort of flagging for themselves as coercive. So there are a lot of different issues that we can think through that are affecting our ability to measure free choice. Some of them might be addressable with better survey questions and with more rounds of cognitive testing and tweaking the item wording. But we also might be facing some sort of fundamental issue on whether or not this can be measured with survey questions. So there's still a lot of work to do. In terms of our next steps methodologically, we're planning to use a range of latent variable modeling techniques to try to narrow down the range of survey items we have to those that tell us the most about contraceptive autonomy in the most parsimonious way. And hopefully this will help us both generate evidence of measurement validity as well as reduce the survey burden that is required to measure this concept, because the ultimate goal for this is to get these questions onto every single family planning survey in the world, because I know that the only way that this will have any kind of impact on programs is if it's measured routinely and repeatedly over time and between contexts. So just to sum up very quickly what I hope we can take away from this research, the contraceptive autonomy study helps to conceptualize contraceptive coercion and autonomy and situates these phenomena as part of a racialized, gendered, and politically contested development initiative. Our study finds that a range of coercive practices from the subtle to the overt can be found even in a model family planning program when that program is motivated by contraceptive uptake targets. And we find that new modes of measurement might be able to help show the ways that programs are either providing or failing to provide person-centered care. These results, I hope, argue for an anti-colonial and justice-based approach to global reproductive health that takes power away from philanthrocapitalists and from governments in the global north, and instead resituates the locus of power and decision-making in the communities that are affected by these types of policies. And of course, we need to develop a range of new measures that will help center the voices of contraceptive users and their own desire for their bodies and for their lives. And so I will say that this study is maybe a first step on this path, but we have a really, really long way to go. So with that, I'd like to acknowledge the funders of this project, and then thank you all so much for listening to me talk.
Thank you. I hate that the end of Zoom talks ends with so much silence, especially given that incredible presentation and the beautiful visuals and the really striking examples. I have a ton of questions for you, but I won't take advantage of my my role quite yet. I'll open it up to others first. Feel free to just unmute and ask questions if you want. There's too many of you for me to see. Oh, David, okay.
Hi, Leigh. Thank you very much. Can you hear me okay?
Yeah, hi, David.
Hi. So, I just wanted to get your views on the work that Mahesh, Cairo, and I have been doing on measuring unwanted family planning. So just to let people know, this is a measure based on discordance between fertility desires. So women who want children in less than 9 months, but are using family planning. And I think it's not, it's not conceptually the same as your autonomy, but I think it's related and has the advantage it can be measured with existing DHS data. And we find about 2.1% of women worldwide have unwanted family planning. And then Jordan at 7.1%, which we think is linked to IUDs, which are women getting difficulty removed. And now we're adding questions to DHS probing the reasons for this unwanted family planning. And so just, I think if you could say a little bit about what you think about our measure and, how it relates to your approach.
Yeah, thank you for that question. I think it's a really interesting approach, and I'm all for trying to use the existing data that we have in better ways. So if there's something different that we can start measuring with DHS data, I think that's a really sort of smart and innovative thing to do. I think that, if I may, I would say that the measure that you are using falls short of sort of this sort of true focus on contraceptive autonomy in one key way, which is assuming that everyone who wants to avoid a pregnancy also wants to, or assuming that everyone who isn't actively seeking a pregnancy needs to be using family planning or needs to be using a method of contraception. And that's a normative assumption that I don't necessarily think bears out in practice. So there are lots of reasons why people might not want to use contraception, even if they're not actively seeking a pregnancy. I talked about that a lot in my PDR article from a couple years ago about unmet need. I think maybe this approach shares a lot with that unmet need measure, which is first of all, relying on a binary conception of fertility desires or pregnancy intentions, which I don't think the research really supports anymore. There's been many years of research on sort of how unstable that question is. And then there are lots of reasons why people don't want to use contraception, even if they're not seeking a pregnancy. And it might be that they're not having very much sex, or it might be that they don't like the way contraception affects them. Or it might be that the kind of sex that they have, maybe they're queer and the kind of sex that they have doesn't expose them to pregnancy. And so there are all kinds of assumptions built into the assumption that there's all kinds of normative judgments built into the assumption that anyone who's not seeking a pregnancy in the next 9 months shouldn't be using contraception, right? So this is sort of the reverse of unmet need. Like people might want to maybe want to have a pregnancy soon, but want to be using contraception up until that time, or they're using contraception for other medical reasons. Like there's so much going on when we conflate pregnancy desires with contraceptive desires, I guess is maybe what I want to say, that I would say that we sort of need to connect those two things. And if what we care about is contraceptive coercion and contraceptive autonomy, then I think that that's what we need to be measuring more directly. And David, I'm happy to keep talking about this.
Yeah, I just ask a follow-up question just by, I think when you first presented these ideas, I saw them, 4 or 5 years ago. I think the reaction in the field was very adversarial to you.
Yeah.
And I get the feeling, though, there's more general acceptance of these ideas now in the field among, and I think at the beginning, there was a strong advocacy group who were very much against you, but I think the field is moving in your direction. Do you think that's true? Are you still getting the same problems, or is it the field moving?
I think you're absolutely right that the field is moving in this direction. There was an IUSSP panel recently that held a conference on this. USAID and Gates and a lot of the big funders do seem to be recognizing that this is a problem. And so for me, the way I conceptualize sort of my role now is to keep trying to push folks to sort of stay true to the actual. I'm worried about sort of another rhetorical shift that's not that doesn't reflect an actual substantive shift. And so I sort of see my role here as keeping folks from adopting the rhetoric of contraceptive autonomy without adopting the spirit and the actions that it calls for.
Yeah, I would just like to say I think you were incredibly brave
Thank you, David.
to bring this up, and I think pushing against the tide initially. And I'm really happy if the tide has turned a bit in your favor.
I really appreciate that, and I appreciate your role also and your support when all that stuff was going on.
Leanna?
Oh no, I was just awkwardly clapping in the corner.
Oh, got
before
it.
that statement.
Sorry, I can't see everybody. Do you have a question, or shall I move? Okay, go.
No, not at the moment. But
Okay,
thank you.
Alexa?
Yes. Hi. Thank you so much, Leigh, for this talk. I'm an MPH student here at Chan, and I also am a physician assistant. I work at Planned Parenthood. So I offer a lot of contraceptive options to patients, but I know that this depends very much on the availability of what we have in our clinic. And so I'm curious, especially when your studies involve clinics and settings outside of the US, what are you defining as a full range of contraceptive options? Like if, and does that vary based on your setting? And maybe I missed that, sorry.
Yeah, no, you didn't miss it. I didn't have time to go into it, but I'm really happy to talk about it. So we do view limited method mix as a form of structural coercion, because like if there's only implants, you don't have a lot of choice. But we're also really sort of pragmatic and understand that it's really unreasonable to expect every contraceptive program in the world to have every single method available to every single person at all times. So we designed full choice to reflect at least one method from each of these contraceptive attribute groups. So people should have access to at least one LARC and at least one short-acting method, at least one hormonal and at least one non-hormonal, at least one female controlled and at least one male controlled method. So that even if there aren't all the methods, if one type of contraception is really important to someone, they would at least have some access to something resembling their method. But hopefully we can work towards a world in which we're expanding method mix and method availability so that everyone has access to their preferred method at all times.
Thank you.
Maggie?
Hi.
Hi, Maggie.
How are you? It's so good to see you. It's really fantastic to have you back here, and totally agree with everything that David said about your sort of bravery and, you know, kind of getting to the heart of the issue. I think one of the things that has made your work influential is, you know, the deep conceptual and theoretical work that you've done, and that's what makes it really, I think, you know, resonate and hard, you know, makes it harder to kind of sort of dismiss as not, you know, not happening very often. I think you know, you've done a really important job of sort of reconceptualizing what we should be doing. Jessica and I talk about the concepts in your work, I mean, basically constantly when we're designing studies. So my question is, and I don't feel like we have come to a good answer in a measurement sense about how to design, you know, if you think about a family planning support intervention that is attempting to provide that reproductive autonomy, how do you measure its success? And I would say that's something we've talked about so often. And I would just love your advice about sort of how to think about it, that and how to approach that given everything that you've learned and all the challenges that you've mentioned.
Maggie, I wish I had a good answer. It's a really good question. And I wish I had a good answer. It's just really, really hard. And one of the reasons that we've been measuring contraceptive uptake or contraceptive use as the goal for so long is that it's so easy to measure. And it's pretty clear, like you're either using a method or you're not. Whereas the rest of the stuff is really, really fuzzy. I just don't have a good answer for you yet, but I know that like we're working on it. Some good news that I can share is that the NIH recently scored my KO1 award very highly. So I'm not taking anything for granted, but it's probably very likely that I'll have funding to like go do the next round of cognitive interviewing around these questions in Kenya and Nepal is what we proposed. And so I don't think we have, like, for example, good survey questions on free choice yet, but I hope that in a few years I can come back and say, like, we have them, we have the good questions. Maybe they won't be perfect. I think that already programs are starting to sort of change how they're conceptualizing success. So I'm working a lot with like the Sayana Press folks and the Implant Access Initiative and some of these sort of single method family planning initiatives to think through with them how they can measure whether or not their program is doing a good job of introducing a new method without trying to overemphasize that single method. And so I guess maybe all I can say is I think a lot of smart people are noodling over this, but I don't think we have it figured out quite yet. And you and Jessica are two of the smart people over it. So I'd love to hear what you've come up with as well.
Leigh, if I could take the liberty to ask a question also. I think, as you said, I think two of the things that make measurement so incredibly challenging, one is that preferences are completely dynamic, right? Like I might have wanted that method until I felt what it feels like to have those cramps from a copper IUD. And I might, there's changing so frequently. And the other is, like you said, sort of pregnancy intention is so not binary. Although it seems like there are better measures now that capture the nuance of pregnancy intention. I'm wondering one thing I think about a lot is what the role of like the contraceptive counseling is really complex. Like if you look at those the like sheets that compare all the different methods and the pros and cons, like the thing that immediately comes to my mind is like the mind blown emoji. Like it's really an incredibly hard problem. And I wonder how much of the fact that this isn't going right comes from how difficult the choices and how brief healthcare encounters are in these systems.
Yes. Yeah, yes to all of that. I actually remember, so the first definition of informed choice wasn't sufficient information, it was complete information. And I remember sitting in a committee meeting with Maggie, and Maggie, no, people do not need complete information to make a decision. I'm a busy woman, like, do not keep me in a counseling session for 45 minutes talking to me about every single method when I know what I want. So I think for free choice, we can sort of, I think, maybe all come to a consensus that like no amount of coercion is okay. For informed choice, how much information someone needs to have to make an informed decision, I think is a real judgment call, and reasonable people, I think, could really disagree about that. And you're right that I think for the most part, like, the healthcare providers are doing the best they can under like really, really, really challenging situations. And that's like under all kinds of constraints about like time and the complexity of this. I think some folks are trying to use different kinds of job aids and mHealth things to help people, like, you know, mobile apps to help people choose their contraceptive method. Actually, there's an RO1 that's under consideration right now to use a mobile app in Ghana to help people make an informed choice. I think maybe those ideas hold some promise, but I think you're right that there's a lot of challenges to doing person-centered care. The incentives are not there, and that's one of the reasons why I think if we sort of change the measurement incentives, that's maybe one lever we could have to affect what goes on in that clinical encounter. But I'm with you that I think we should like assume goodwill on the part of the individual providers. I think folks are really trying their best to do a very hard job.
Thank you, Anna.
Hi, Anna.
Hi, Leigh. I wanted to say hello. Sorry, I was only able to log in late because I'm just arriving from New York and my train was a little delayed. But it's wonderful to see you. I just wanted to echo the great complimentary words you got from other colleagues and tell you how much your discussion reminds me of the long discussions we've had over maybe 5 years. And well, it's amazing to see how you move this agenda forward. And I also want to share with everyone who doesn't know it that you have an amazing publishing track record. So thank you, Leigh, for the work you've done and you will keep doing for the field. It's really, really, really important.
Thank you, Anna. I'm going to try not to cry. Thank you for those really kind words. I really appreciate it.
Sure, what a pleasure.
Maggie, is that a residual hand or is that a new hand?
Sorry, residual.
Okay. Anyone else have any questions? We all want your advice on how to measure this, Leigh, but I feel
know.
We could have like so many long discussions about the
I really wish
challenges.
To David's point about how the field is turning, I really do feel like there's a tremendous hunger on the part of just about everyone I talk to measure this, and it breaks my heart every time I have to say like we haven't quite cracked it yet. But we're working on it, and maybe there's some sort of coordinating work we can do to bring folks interested in this together, because 30 heads will be better than one, and I'm sure there's a lot of really sort of fruitful cross-pollination that could happen if we got folks in a room together.
Well, maybe I'll ask you just one more question if no one has one. I know you've been thinking about what factors are at play in creating barriers to LARC removal. Do you want to talk about that a little? One thing we were talking about before you presented was that some people, like, for example, if you have pregnancy-related insurance, are covered for the insertion, but then your insurance changes postpartum and the removal is not covered. And, there are a number of cases like, things like that where programs make insertion very easy, but removal is not quite as easy. Can you maybe just give us like briefly the landscape of this work?
Yeah, thank you for that question. Jessica, you work more on sort of on the high income countryside, and so I know less about sort of how the insurance coverage works. But I think that like what we're seeing both across the global north and the global south is like an extreme enthusiasm about putting LARCs in, and then like decidedly less enthusiasm about taking them out when people want. And so I do have some publications on this, like both qualitative and quantitative. One issue in the quant work that came out using PMA data was facilities were stocked with insertion supplies, but didn't have removal supplies all the time. For implants in particular, the removal process is technically more challenging than the insertion. And so in the context of task shifting, if there's a health post with someone with sort of a less robust medical training, the removal of implants that have migrated or that were deeply placed can be particularly challenging. And if we go back to these measurement issues, if we're all trying to measure modern contraceptive prevalence and we have our targets and our quotas for modern contraceptive prevalence, it looks bad for us to take out a LARC. And in the context of really resource constrained settings, LARCs are expensive, and people don't want to see them. There's this idea that like if you take it out too early, it's wasteful, and you don't want to see like this perfectly good medicine go to waste. So I don't know, for those of you who work in really sort of really poor countries, like you'll see like people like ride their tires till the tires are like shredding apart, right? And people are like squeezing every last ounce out of every last resource that they have. And so the idea that there's like this perfectly good medicine that we're not using every last bit of, I think sort of like for good reason, maybe feels like it's not a good use of the country's resources. And then I think there's a lot of patriarchal stuff going on around like women are experiencing a lot of side effects from implants in particular, but the idea is like that's like you're supposed to bear it. Like women feel bad because of contraception, but it's our job to prevent pregnancy. And so like you're supposed to live with it. And so there's all kinds of stuff that's going on that makes LARC removal not anyone's priority, even though from a reproductive rights or justice perspective, it should be at the very, very, very top of our agenda. There's a feminist scholar named Adele Clark who talked about LARCs as an imposable method. And I think if we think about them as imposable, it will help us sort of reframe both the way that they can help people who want them, like I'm an IUD user myself, but also sort of the dangers of that type of method for people who are already marginalized in multiple ways.
Great, thank you. That seems like that's a pretty crystal clear research agenda to make sure that organizations that are funding these family planning programs take their fundees to task to make sure that they are making these services available alongside.
Yeah, I had an argument with a friend of mine who was doing a project in Madagascar where like the roads become impassable in the rainy season, so they're using drones to deliver contraceptive commodities to health posts during the rainy season. And I had a huge argument with this person because they were putting the insertion supplies on the drone, but they kept arguing that there wasn't enough room on the drone for the removal supplies. Yeah, and so right. If you're going to put them in, you also have to take them out. And like we have to just make that really clear to folks.
Awesome. Thank you for this inspiring and informative talk, and congratulations on all your success. We look forward to seeing your career evolve. Thanks for joining us. Thanks, everyone.
It was just such a pleasure to see you all again. Thank you so much for having me. This was a real joy.
Thanks all.
You're crushing it. So great to see you.
Thank you. Okay. Bye, everyone.